Hello, greetings from Barcelona. I am Ricard Cervera from the Department of Autoimmune Diseases at the Hospital Clinic in Barcelona. And together with Silvia Aguilera, which is the IPAC representative at the working group on the antiphospholipid syndrome, we are going to moderate this webinar on the 2023 ACR EULAR AntiPhospholipid Syndrome classification criteria. As I can see that Silvia has just joined the group, I will pass the microphone to Silvia. Silvia, hello, and the podium is yours.
Thank you so much. Sorry for the delay. Great. So welcome, everyone. I guess, Ricard, you introduced us both. I just wanted to do some housekeeping. So the next slide, please. So some rules for this webinar. So this webinar will be recorded and available in the Reconnect's YouTube channel or in our website. If you have any questions during the webinar, you can use the chat or the bar that says Q&A at the bottom, and you can put your questions there. And the questions will be addressed at the end of the presentation by Professor Zuily. So I give the floor now to Ricard, that will introduce our speaker today. Thank you.
Thank you very much, Silvia. And it is for me a great pleasure to introduce Stéphane Zuily. He is from the Hospital of Nancy in France, but he is one of the fathers of the topic that we are going to develop today. We have recently released new classification criteria for the antiphospholipid syndrome. We have this as a result of a large amount of work of hundreds of people from different continents, with the endorsement of the two main federations of societies of rheumatology, the American College of Rheumatology and the European Federation, the EULAR. But there were mainly two persons that took the leading role in order to organize this new classification criteria. On one side, it was Doru Kerken from the States, New York, and on the other side was Stéphane Zuily from Europe. And so we have firsthand the information on how these new classification criteria were created, were developed, and which are the new improvements that we have in order to better classify these conditions. So it's really an honor to have at this webinar of the ERN Reconnect, Dr. Stéphane Zuily. Stéphane, the podium is yours.
Dear Ricard, dear Silvia, thank you very much for your very kind invitation. Thank you to the ERN Reconnect for giving me this great opportunity to present and to disseminate these new classification criteria. And I think for the APS world, these criteria are and will be important. So now I'm going to share my screen with you in a couple of seconds. Yes, so I think you may see my screen right now. So this new 2023 ACR EULAR classification criteria for APS is a real teamwork. Exactly as you said, we made perhaps 10 years to create these new classification criteria, and I would like to acknowledge all my friends and my colleagues that make it possible together today. Here are my disclosures, not related to this talk. So now let's go deep in the world of APS. APS was initially defined as a condition associated with thrombosis or obstetrical morbidity. And in 2006, the Sydney-Sapporo criteria were published and updated in order to identify homogeneous groups of patients. This definition was very clear. It was easy to recognize patients with two things. First, a clinical manifestation, either thrombosis or obstetrical morbidity. And second, APL, meaning antiphospholipid antibodies. However, we all know in the field of APS that APS is more than we think. It's patient with arterial or venous thrombosis, but also patient presenting non-criteria manifestations. When I say non-criteria manifestations, I mean patients with other manifestations than thrombosis or obstetrical morbidity, such as livedo, a dermatologic condition, such as thrombocytopenia, valve disease, and other things like that. We also are in charge of patients with one very infrequent form, but very severe form of APS that Ricard Cervea is the father, which is the catastrophic antiphospholipid syndrome, very important condition, and in 1% of patients with APS. And also another phenotype of patient with microvascular impairments. And at the end, we have also patients with antiphospholipid, but without any manifestations. I can call them asymptomatic antiphospholipid carriers. So in the spectrum of APS, we can see that the clinical presentation can be very wide. And what was a challenge, it was to renew the definition, to renew what we all know based on 15 years of research in comparison with the Sydney criteria, and to do a new classification criteria for defining APS. The clinical spectrum is very wide. You can see here, of course, a very common stroke on your left-hand side, livedoid vasculopathy, pulmonary embolism. At the bottom left, you can see here thickening of the valve with the endocarditis-like presentation, and in your right-hand side, a patient with a chorea, which is, of course, a very uncommon manifestation seen in APS. So this very wide clinical spectrum is a challenge for all of us because, of course, we are saying that it can be under the umbrella of one syndrome, APS, but how can we handle that? So one question this question was asked to us, to experts, in order to renew the classification criteria, was related to the likelihood of having APS. And when I ask you this question, which patient, the patient on your left-hand side or right-hand side, has the highest likelihood of having APS? When you compare these two patients, two male 48-year-olds, same cardiovascular risk factor, but on your left-hand side, you will have a different APL profile, antiphospholipid antibodies profile, than on your right-hand side. I would say, and I asked this question to many of you, and all of you said, okay, this patient on your left-hand side with the more severe antiphospholipid phenotype could be associated with the highest likelihood of having APS than the patient on your right-hand side. And why this patient on your left-hand side could be considered as having a highest likelihood of having APS? Because we all know that we have three different biomarkers, lupus anticoagulant, anticardiolipid antibodies, and anti-beta-2-GP1 antibodies that are very important in the laboratory workout of APS. And we know since more than 20 years that when you have the presence of a lupus anticoagulant, this test based on hematologic test in comparison with ELISA tests and immunologic tests, this lupus anticoagulant is associated with a higher risk of venous thromboembolism than anticardiolipid antibodies. It has been proven in patients with lupus and in patients without lupus. So it's admitted that this lupus anticoagulant is associated with the highest risk. We have exactly the same data for arterial thrombosis here in ischemic stroke. This lupus anticoagulant test is associated with the highest risk of ischemic stroke in this study, and it has been repeatedly found in different studies. And at the end, we also know that the cumulative risk of different tests yield a higher risk of thrombosis or clinical manifestations. Here, we know that triple positivity, the association of lupus anticoagulant with anticardiolipin antibodies with anti-beta 2GP1, is associated with a higher risk of thrombosis in this landmark paper. So if I want to summarize, the higher number of tests positive, the higher the risk, the higher the titer, the higher the risk. And when you have an IgG phenotype, the risk is higher than IgM phenotype regarding thrombosis. How to test and how to identify those antiphospholipid tests? It's important to know that the persistence of APL positivity is mandatory. Why? Because we know that the risk of false positivity can be very high for instance, in the case of viral infections or lupus flare, for instance, or in cancer or hemopathy. And we also know that the risk of false positivity can be high also due to anticoagulant treatment. For instance, DOACs is highly correlated with the high risk of false positivity of lupus anticoagulants. So first, persistence is mandatory. Second, we all know that depending on the threshold and the titer, you will say this patient is positive or not. And it's very important to go back to ISTH guidelines in order to confirm the presence of antiphospholipid tests. So now, when I want to go back to the main question, which patient had the highest likelihood of having APS, and I would like to compare these two patients. The patient on your left has several risk factors. The patient on your right has no cardiovascular risk factor. And my question is, which patient has the highest likelihood of having APS? And you would respond the patient on my right, yes, of course, because the patient on my right has only antiphospholipid antibodies, and then the impact of these antibodies and the responsibility of and accountability of these antibodies is very high in comparison with patients with a high number of cardiovascular risk factors. It has been shown in several studies showing that the impact of cardiovascular risk factor or VTE risk factors is very strong in APS. Here, in patients with lupus anticoagulant and oral contraceptive pill containing estrogens, the risk is multiplied by 21. When you add smoking, then you multiply the risk of MI, myocardial infarction, by 33. And if you want to know the risk of stroke, ischemic stroke, when you add smoking to lupus anticoagulant, you will multiply the risk by 87. So there is a clear cumulative interaction between those two risk factors, antiphospholipid antibodies on one side and cardiovascular risk factors on the other side. And it has been greatly and elegantly merged in a risk stratification tool, the GAP score, the global APS score, in which you have several cardiovascular risk factors together with different antiphospholipid tests, and the higher the score, the higher the risk. It has been clearly demonstrated in the original cohorts and in validation cohorts. Last question. Which patient has the highest likelihood of having APS? The patient on your left has only one history of ischemic stroke. The patient on your right has a different manifestation, ischemic stroke, pulmonary embolism, and Liebman-Sachs endocarditis. And I would say the patient on my right has the highest likelihood of having APS. Why? Just because there is a cumulative impact of different manifestations together, which correspond to a highly likelihood of having APS. So to summarize, we can clearly identify that according to the antiphospholipid profile, first. Second, according to the cardiovascular profile and the presence of cardiovascular risk factors. And third, according to the number of manifestations, the probability and the likelihood of having APS will be different and will increase. So we continue our journey in order to identify which clinical manifestation would be relevant for the new classification criteria. And we performed during almost 10 years several meta-analyses in order to determine the association between non-criteria manifestation, valve disease, pulmonary hypertension, livedo, nephropathy, thrombocytopenia, and hemolytic anemia, to get associated with different antiphospholipid tests. And we found that in each green square, it corresponds to a positive and a significant association between antiphospholipid test and each manifestation. And when it's in red, it means that there is no significant association between the test and the manifestations. And we found that lupus anticoagulant, that is known to be clearly associated with thrombosis and obstetrical morbidity, was associated with all non-criteria manifestations, and all these non-criteria manifestations were clearly associated with clinically relevant antiphospholipid profile, lupus anticoagulant, and IgG anticardiolipid antibodies. So based on this rationale, I will just give you now what are the new 2023 ACR EULAR classification criteria based on all this data I've presented to you a couple of minutes ago. And I will just say to you again that it was a great and a major international collaborative effort with more than 80 scientists between 2014 and 2023. I had a great pleasure to collaborate with my colleagues Doru Kerkan and Meda Barbaya, my colleague's friend and co-first author in for these classification criteria. And of course, the SCORE planning group made a tremendous role and crucial role for creating these new classification criteria together. The main objective of this criteria was to determine for research, highly specific criteria to identify homogeneous groups of patients with a high likelihood of having APS. So I will just give you details and important data regarding the difference between diagnosis criteria and classification criteria. First, the goal is different. For classification criteria, you need well-defined study sample representative of the majority, not all the patients. For diagnostic criteria, you can include all the patients, including unusual presentations such as chorea, as we've seen a couple of minutes ago. For patients, for classification criteria, we need homogeneous groups of patients in order to do research. For clinical care and patient management, for diagnostic criteria, we can have heterogeneous groups of patients. Billing and reimbursement, classification criteria has no impact, and diagnosis criteria can have an impact. And classification criteria don't have any impact on treatment. It's for research only, and same for diagnosis. So you will say to me, great, it's great to have classification criteria, but how can I handle this difficulty, and how can I use this classification criteria for my everyday patient management, which is one main question. And because Sydney criteria were also classification criteria, it's important to know the advantages, but also the pitfalls or the limitations of classification criteria in order to know how to use them. So these classification criteria, in order to classify your patients, it will be completely different than before. Before, it was either thrombosis or obstetrical morbidity or both, plus antiphospholipid antibodies. Now it's completely different. It's based on a score system, different points, according to the ACR EULAR methodology that allowed to create classification criteria for systemic sclerosis, vasculitis, lupus, and so on. So different manifestations and autoimmune diseases. So in these classification criteria, and especially in the APS classification criteria, the first step 1, is an entry criteria. It means that if you don't have this criteria, you cannot go forward and you cannot classify your patient, or you cannot enter your patient in the classification process. The entry criteria is the association of at least one documented clinical criterion within domains 1 to 6, plus a positive antiphospholipid test, either LA, moderate to high titer ACL, or anti-beta 2 GP1, IgG, or IgM, or a combination of these APL tests within 3 years of the clinical criterion. If you don't have these entry criteria, do not attempt to classify. If present, you can go forward. Second step corresponds to clinical domains. Clinical domains, you will have 6 clinical domains, and I will give you the details in a couple of seconds. 2 main informations. First one, do not count a criterion if there is an equally or more likely explanation than APS. For instance, if a patient is treated with chemotherapy and then you identify a thrombocytopenia 7 days after chemotherapy, of course, this thrombocytopenia will not be counted as a criterion for APS, but will be associated with chemotherapy. So now, don't count this item. Second main information, within each domain, only count the highest weighted criterion towards the total score. If in one domain you have a patient with several manifestations, and this patient can check the box of different items, just choose the item with the highest score. Third step, laboratory domains, identify which APL profile the patient presents. And then at the end, if you are at least 3 points from clinical domains and at least 3 points from laboratory domains, then you can say that your patient can be classified as having APS. Here are the domains. Domain 1, macrovascular, venous thromboembolism, and you have 2 different domains, two different domains, the venous thromboembolism 1 and the arterial thrombosis 1. In the first one, VTE, you can have patients with VTE with a high-risk VTE profile, such as VTE after surgery, or in the context of cancer, because the high-risk VTE profile is defined as surgery or cancer, for instance. Then the patient will have only 1 point. And VTE without high-risk profile, it will be exactly the same for arterial thrombosis. And remember, the patient with ischemic stroke, a patient with ischemic stroke without any risk factor, the likelihood of having APS is higher than the patient with the ischemic stroke with several cardiovascular risk factors. Then, according to this rule, you will have more points when the patient will have ischemic stroke or MI without a high cardiovascular risk profile. Then you will have another domain, which is the microvascular domain, and you will have 2 different scenarios. First scenario, microvascular items, but with just a suspicion, with no confirmation. Then you will have 2 points. And if you confirm the diagnosis based on biopsy or imaging, then you will have a higher likelihood of having this clinical manifestation, and the number of points will raise up to 5. Fourth domain, obstetrical domain, with different manifestations, and according to several literature reviews, meta-analyses, task force reports, and consensus meetings, we identified that the association of preeclampsia together with placental insufficiency were clearly associated with the higher risk of having APS, with a number of points of 4. 2 new manifestations enter in the classification process: cardiac valve disease with thickening and vegetation, and hematology with thrombocytopenia, mild to moderate thrombocytopenia between 20 to 130 Gig per liter, associated with a number of points, then it will be possible to classify a patient even without thrombosis or obstetrical morbidity with the classification of APS, which is clearly new. I'm going to finish my presentation in 1 to 2 minutes. I will just like to say that these new classification criteria are associated with the higher specificity than the revised Sapporo criteria. However, of course, when you increase the specificity, you will decrease sensitivity, but our goal was to identify a higher likelihood of having APS with a higher threshold, with a higher specificity. It was the original goal of this new classification criteria. I would like to conclude by saying that APS is a challenge in terms of classification, and now we can have highly specific non-criteria manifestation who are now included as criteria, and it was not the case in the previous classification criteria. This classification criteria is based on risk factors and also antiphospholipid laboratory profile, which is clearly new. And all criteria are defined very precisely. I would like to thank all my colleagues, especially the core planning group and all the colleagues in the world that contributed clearly to this new classification criteria. I would like to acknowledge Zorica Khan and Meda Barbaya. And as a gift, because we clearly understand that this new classification criteria can be a clear difficulty in assessing patients, because the classification criteria process is clearly more difficult and perhaps more precise with different criteria. We created software in order to classify your patients and to decrease the difficulty for classifying your patients. You will be able to identify and to find this classification criteria software on apsnancy.com in the resources box. I would like to thank you very much for your attention, and I will remain at your disposal for any questions. Thank you.
Thank you so much, Stéphane. We do have some questions in at least the question box. So the first question for you, in your setting, do you test immediately if a patient develops a stroke, for example, or would you wait first after 12 weeks?
So the question is perhaps the chronology of testing after thrombotic episodes. Mm-hmm. In fact, every scenario is possible. You can test at the beginning. However, when you test at the when the thrombotic episode is very close, you can have a high risk of false positivity. For instance, if a patient is treated with anticoagulant treatment, then you can have a false positive test. If there is inflammation too, you can have a false positive test. That's why even if you test at the beginning or just a couple of days after a stroke, don't forget to control your test 12 weeks apart. It's very important. Another scenario would be to take our time, and when the question of the treatment duration after pulmonary embolism, for instance, is clearly the main question, then you can test your patients several weeks or several months after the first episode in order to identify the best treatment strategy.
Thank you so much. There's a very interesting question in the chat box regarding the relationship between COVID-19 and the presence of antiphospholipid antibodies. Is there something specific that should be considered in this case?
Yes, very, very good question, because when patient with COVID during the beginning of the pandemic in 2020, we found a lot of patients presenting thrombosis. And then the question was why these patients are presenting thrombosis. And a couple of teams identified that we had a high prevalence or frequency of APL positivity in these conditions. However, we made a great job, international consensus based on this problem, and we found that each time a positivity was found at the beginning of COVID, the persistence was very low. Of course, it's possible to identify a patient with APS, but the frequency of identifying an APS patients in patient with COVID-19 is very low, and most of the patients with APL positivity at the beginning had negative antiphospholipid test at the end. So we know that infections, viral infections or bacterial infections, can trigger the APL positivity, and then when the viral host is gone, then the APL positivity can disappear. So it's not a clear link, it's just APL mediated by COVID-19.
Great, thank you so much. Another question. We found a comb-like pattern at capillaroscopy in antiphospholipid antibodies IgM, and IgG positive patients. Will this be considered in future capillaroscopy as an additive test? This is for the next, someone thinking about the next classification criteria, maybe.
Yes, of course. I think it is very, very important because the hidden part of APS is the microvascular world. And we are convinced that there is such very important impairment of microvascular vessels, especially in patients with small vessel involvement, nephropathy, or patient with livedo-racemosa. We know, we performed several studies showing that it's not only a problem of clots, it's a problem of vasculopathy with intimal hyperplasia. And we found that on patients with livedo, also in patients with renal impairments in APL nephropathy. And we know that capillaroscopy is a way to look at the small vessels. So it will be very interesting to look deep in this problem using capillaroscopy in those patients with the suspected microvascular impairment, because I think that this impact on small vessel is systemic on all the body. So very good, very important and interesting topic.
Mm-hmm. Another question. Well, first, thank you for your very gorgeous presentation. I wonder if the antiprothrombin antibodies have a strong relevance in the case of negative results of the rest of antibodies.
So yes, it's a very important and very interesting field. We know that antiprothrombin antibody, and especially the new ones, the antiphosphatidylserine prothrombin, anti-PSPT antibodies, were found to be clearly interesting in the field of APS. The main question is that do we think that these antibodies could have any additive value compared to the traditional ones, lupus anticoagulant, anticardiolipid antibodies, and anti-beta-2-GP1. And based on several studies, but research is ongoing, but based on several studies, we found that these anti-PSPT antibodies were in some cohorts clearly associated with lupus anticoagulant, and the frequency of isolated anti-PSPT without any other test could be not so frequent. It can be present, but not so frequent. And it will be very interesting to follow this patient with isolated anti-PSPT and to find and to determine whether this patient with isolated anti-PSPT could have the same prognosis than patient with lupus anticoagulant or other traditional assays. So I think that research remains important in this field because anti-PSPT is a very, very good biomarker that could be considered in the future as new classification criteria in the field of laboratory tests.
Great. I have a question. We know that classification criteria should not be used for diagnosis, but the reality in the field is that some doctors do use them. And maybe it's a question for maybe also for Professor Cervera on how would you manage a patient that has been diagnosed with APS using the previous classification criteria, and with the new one, suddenly they are not? what do we do in these cases? Because we are starting to see patients in this, that they're even, doctors are changing their medication.
Yes, of course. We understand that because, of course, the threshold for determining patient with APS is now higher. So it's more specific, and we can lose some patients, of course. So this is very important. First, classification criteria is for research. We all know that. Second, when those patients are determined using these new classification criteria, we are more than convinced that those patients have APS. In the middle situation, we have to say that clinical judgment should be used, and clinical judgment, even for guidelines and international guidelines saying that in those cases use this treatment, in this case use this treatment, clinical judgment has been always very useful for identifying the best treatment for our patients. Because even if research is ongoing, even if we updated this classification criteria based on all the best evidence to date, we have, in some cases, patients that are challenging and they are not going in the boxes of this new classification criteria. For instance, a patient with chorea, thrombocytopenia alone, and high titer antibodies, this patient cannot be treated and cannot be classified as APS because this patient cannot enter in the classification criteria process and will not be classified. However, how to treat these patients? In this case, the clinical judgment should be used, and discussion with colleagues in multidisciplinary approach is mandatory, I guess.
I just fully agree with what Dr. Zuily has mentioned. I think that it is very, very important to stress once more that these are classification criteria, not diagnostic criteria. And that in the clinical setting, when we physicians are facing patients with a suspected antiphospholipid syndrome, is the clinical judgment what we have to use in order to diagnose the antiphospholipid syndrome. These criteria are mainly for research purposes, and the additional thing is, as also Dr. Zuily stressed, for stratification in order to see which probably are more severe cases, those that probably have a higher risk to develop more thrombotic events, more complications, depending on the presence or not of additional risk factors, depending on the isotype of the antiphospholipid antibody, depending on the number of tests that are positive, it is single or double or triple positivity. This is a stratification, but diagnosis, as I think probably is a number one lesson of this talk, diagnosis depends always on clinical judgment. So I think that it is, as Sylvia stressed, that maybe some patients, the treatment is changed now, depending on if they fulfill the previous, the CINE or the Sapporo classification or the new ACR EULAR classification criteria. This is a mistake. So you can change the treatment depending on the manifestations, depending on the clinical judgment, depending on the severity, depending on other factors, but not just if they fulfill or not fulfill these criteria.
Great. And next, another question. Oh, this is an interesting one. Do you have any comments on the COVID AstraZeneca vaccine and the risk to elicitate an APS syndrome?
So the question is related to the impact of vaccines on the generation of APS.
Yes, specifically they are asking about the AstraZeneca one that was,
yes,
that was very.
Yes. So I've seen that AstraZeneca or with vaccines with the same protocol and the same methods were associated with some very uncommon thrombotic cases known as VITT, vaccine-induced thrombotic thrombocytopenia. It has been clearly well identified. We know that in the field of autoimmune diseases, that infection can trigger beginning of autoimmune diseases. We also know that in some other cases, medication and vaccine can trigger predisposed patients with a high likelihood of having any autoimmune diseases. And then in some circumstances, viral infections or treatments such as vaccines or other treatments can trigger autoimmune diseases. So it can be, it is known. Minocycline, for instance, was clearly associated with induction of autoimmune diseases. So I would say that I would not be surprised. However, I did not make the full literature review regarding AstraZeneca vaccine and APS, and I think it could be a very important topic. I don't know, Ricard, if you have any comments on this question.
Oh, I fully agree with your comments, really.
Great. Another question. Thank you for the great talk. What do you suggest for women with only a spontaneous abortion before the 10th week of gestation, confirmed high titer of APL positivity, and without any other possible cause of abortion?
Yes, of course. Abortion is a tricky world because we, and I think that in Europe, the European Society of Human Reproduction published very comprehensive guidelines regarding the problem of fetal loss and abortion. And in this field, we know that the impact of antiphospholipid antibody is real, but we also know that the impact of many other conditions is also clearly present. Anti-thyroid antibodies, problems of karyotype with the DNA of the sperm of the father, and so different things. So I would say that, of course, if the workout has been comprehensive with so many different hypotheses that were ruled out, then if we have a clinical and, of course, clinical and significant API profile, this would be relevant. And it has been written in the European Society of Human Reproduction guidelines, saying that when you have 2 abortions with antiphospholipid antibodies, then it can be associated, and then you should begin treatment. So it's guidelines for treatment for patient management, not guidelines for research. In the field of research for APL positivity, due to the high number of differential diagnoses, and because we have a strong proof that preeclampsia and placental insufficiency are clearly associated with APL positivity, these problems were put in the first position. However, a patient with a history of DVT, history of thrombocytopenia or livedo, and fetal loss will be classified as APS in our case.
Great. I think there's no more questions in the chat, but I have maybe a last question, profiting from having you both here, both experts. You explained at the beginning that the APS patient can be from asymptomatic to someone having very, very severe disease. Are we missing, is there a piece of the puzzle missing to explain why, or are we missing some antibodies? Would you expect something that we will be finding something in the next few years that would explain why there is such a big, big difference in these APS patients?
Yes, I think that you're real. And the question is, which kind of consequences can we identify in different patients? Because the patients can have exactly the same API profile, but could have different clinical manifestations and different clinical phenotypes. And we really feel and we really identify that several different pathways are impaired in antiphospholipid syndrome. In some patients, this pathway, for instance, the mTOR pathway or the pathway related to nets or to different problems can be activated, or complement pathway, of course. So it means that depending on because we are all different, and we have a different autoimmune system, and because we don't have the same genetic background, and based on this huge complexity, the same antibodies will have different consequences based on different pathway and then different clinical manifestations. So that's why now our next journey will be to identify and to determine which pathway is impaired in different patients in order to find the best solution in terms of treatment.
Great, thank you so much. I think someone is typing a question. I'm not sure if it doesn't seem like it. Okay, I think we don't have any more questions. Ricard, do you have anything to add? Any comments?
Just to thank you really very much, Stéphane, for this marvelous talk. As I mentioned at the beginning, it has been a great honor to have you in this webinar. But certainly, after listening to you, and especially after these comments and these questions from the audience, we really know that we have learned a lot, and hopefully some of the objective, or all the objective that we had when we started this webinar have been fulfilled. So thank you very much for this excellent webinar, and hopefully we manage in the next future even to improve this classification criteria, and especially to know why some patients develop one manifestation, other patients develop other manifestations, some patients develop a terrible catastrophic antiphospholipid syndrome, by analyzing these different pathways using these stratification studies performed for the classification criteria. So again, thank you very much, Stéphane.
Thank you very much to you. Thank you for your great invitation, and thank you to the ERN Reconnect network. Of course, it was clearly a great opportunity for me being with you today. Thank you.
Thank you. We just remind the people watching this video that there are other Reconnect webinars available in the YouTube channel and in the ERN website for you to view. Thank you so much.